Good evening and welcome to the OHSIPP webinar update on reopening Ohio pain clinics. We are so glad you have joined us tonight. We will be starting the webinar promptly in 2 minutes to give everyone a little bit of a time to log on. Again, thank you so much for joining us tonight. We will start the call in promptly 2 minutes. Good evening, everyone, and welcome to the OHSIPP webinar update on reopening Ohio pain clinics. Thank you so much for joining us tonight. We appreciate you being here. We will start the call at promptly 7:02 to allow people some time to log on. Again, thank you for joining us, and we will begin promptly in 1 minute. Good afternoon, everyone, and welcome to the OHSIPP webinar, update on reopening Ohio pain clinics. We are so glad all of you have joined us this evening. We will begin the call promptly at 7:02, which is in just about another 15 seconds to allow others to join the call. Thank you again for joining us. We will start in about 10 more seconds. Good evening, everyone, and welcome to the OHSIPP webinar, update on reopening Ohio pain clinics. We are so very glad that you are here to join us this evening. Our agenda this evening is quite robust, and we are excited that we have such an amazing faculty. I would like to introduce our first presenter, Dr. Ricardo Buenaventura. Dr. Buenaventura obtained his medical degree at Tulane University in New Orleans and completed his anesthesiology residency at Northwestern University Medical Center. He also did a 1-year pain medicine fellowship at the Ohio State Medical Center and is currently up in the Dayton area. He is involved in advocacy for pain management at the national and local levels for the benefit of all patients suffering from chronic pain, and he is the current president of the Ohio Society of Interventional Pain Physicians. Dr. Buenaventura, take it away.
Thank you, Michelle. I'd like to welcome everybody who signed on for this the second OHSIPP webinar. We had our first one about a month ago, and this one is now targeted more towards giving people advice or recommendations on the reopening of pain clinics. Now, you know, the clinics opened up, or rather medical offices opened up a week ago, but we decided to go slow and wait and see how things went and any new developments. And actually, as it turned out, it was a good thing because some things came out just over the weekend, which you'll hear later in this talk. But I'll go ahead and get started out with the introduction, and I'll talk about the OHSIPP blog, where it's essentially a letter or blog that I wrote about the opening of pain clinics. So my talk will essentially go over that blog. But as you know, we're now into about the second month, or almost the third month, essentially, I guess, of this coronavirus pandemic and COVID-19. Fortunately, in Ohio, our caseload has been low relative to some of the other states that you're hearing in the news. But even now, it seems like our caseload seems to be steady or increasing in some areas. So we're not out of the woods. This is something that's going to be around for a while. You know, you need to remember that it's a healthcare crisis and an economic crisis. You know, and there's pushing and pulling on from both sides. The doctors, of course, want to do what's right for the public safety, and the government and the administration, of course, want to reopen the economy. So there's a lot of pushing and pulling there. We're not going to get into the politics of that. We'll just stick with the reopening of the clinics and give you some advice that you can use. Of course, we don't know how long this is going to last. And you're going to have to take some of the stuff that we say and what you learn and put it to use. You're going to have to manage the risks, both in terms of health, your patients, your family, as well as the financial risks, whether it's keeping your practice solvent, but also avoiding some potential landmines of either having a patient get infected and somehow try to blame it on you that they came to your office, or that they caught COVID-19 later after your treatment and they got worse. So these are all things you need to keep in mind as you go forward. So we'll as I said, I'll talk about I'll kind of follow the blog that I wrote, but we'll also touch on the OHSIPP toolkit too. So we'll get started here with the next slide, please. As far as what are we going to do? You need to remember that there you see the address of the blog. Essentially, it's on the OHSIPP website, OHSIPP.org, and you can look for the blog there. As far as the order, essentially, you want to check with your state. Of course, in Ohio, medical offices never shut down during this public health emergency during March and April, but we were limited as far as elective procedures. That's changed, and now as of May 1st, even business offices are starting to open with certain rules, and we'll touch on that a little bit later. You want to remember that you need to prepare your office for patients that are coming into your office. You need to keep control the flow of patients and the volume so that you can maintain the social distance, and then also you need to have a certain amount of PPE available for your staff. It is required for all businesses, including healthcare offices, that employees wear their PPE during the workday. There is no clear mandate that patients need to wear it, but it would be wise to consider that in your offices. So, as I mentioned, you want to organize your schedule for social distancing, and you want to maximize telemedicine because that's actually going to help you. If you're going to be bringing patients into your office and managing social distancing, you're essentially going to be spreading out the appointments and reducing your volume. So by doing telemedicine, you can actually help yourself to increase your volume if you can fill up your telemedicine schedules. Testing is very important. That's something that's going to be very pertinent going forward as to whether your patient has coronavirus. So you want to know that. And again, we'll have a talk on that coming up later. And then consent. So next slide, please. As I mentioned, check with your state. So again, remember, in Ohio, we were essentially shut down in terms of elective procedures, but not as far as seeing patients. We were essential businesses, so we were open throughout. Just that emergent procedures were shut down or prohibited during this shutdown phase through the end of April. Now, of course, we were able to do that, and everybody should be proceeding with that. But of course, using proper social distancing in your office as you're seeing these patients. So next slide, please. As I mentioned, preparing your office. So, and you just want to make sure that you can handle the patients that are coming in, and this will involve things such as, removing chairs in your waiting room and spacing them 6 feet apart. You want to have the schedule such that people come in properly spaced out. Also, you want to avoid drivers or family members. And then you're going to remember that you're going to be increasing your use of PPE. Certainly your staff's going to be using it even at the reception and checkout areas. And then you may be giving some to your patients if they show up without a mask and you so choose to have your patients wear the PPE. So you want to screen your staff and patients, of course. As I mentioned, you have to rearrange your office and you're also for the back office as well, and consider back office staff maybe coming in at later hours or working from home if they can, or coming in if they need to work in the office. Maybe they can come in the afternoon and evening when there are no patients in the office. And again, remember, you want to certainly maximize your use of telemedicine. We won't go into telemedicine specifically during this talk because we covered it before, and I think people are familiar with it. But certainly, telemedicine has been a great help. It's very convenient. I've had some patients, literally, one patient's a mail carrier, and she literally just pulled over on the side of the road. We did her visit, and then afterwards she hung up and went on about her her shift delivering the mail. But so it's been very convenient. And when I saw her afterwards for a procedure, and she said, yeah, it was great because usually she has to take the whole day off from work, and that's a big hassle for her. As I mentioned, maintain your stock of PPE. Going forward, you're going to have to keep in mind that you're consuming this stuff at a faster rate. So you're going to have to order and stay ahead of your masks and gloves for your staff and your office. So this is something that the state of Ohio put out from ohio.gov. This is responsible protocols for getting Ohio back to work. So this is something they issued right around May 1st or soon after. You can see there's across the top the guide and principles. So we want to protect the health of employees and customers and their families. You want to support community efforts to control the spread of the virus, of course. And you want to lead in responsibly getting Ohio back to work. The 5 protocols beneath applies to everything, whether it's a non-medical office, non-medical business, as well as medical offices. So required to wear face coverings for employees and recommend them for clients. There was some debate about whether they were going to require customers, but the governor backed off on that one. Conduct daily health assessments, of course, asking your staff if they have any symptoms and checking their temperatures. Maintain good hygiene at all times, hand washing, social distancing. You should have a hand cleaner available. You want to clean and sanitize all workplaces. And then number 5, as I've mentioned, limit capacity to meet the social distancing guidelines. So even here, they say, you can see, establish maximum capacity of 50% of fire code and use appointment settings where possible to limit congestion. We're hearing talk of restaurants where they're going to be held at 25% capacity. Well, imagine trying to do your work schedules and pay your bills and pay your staff at 50% or 25% of productivity. It's going to be tough going forward, but you need to keep that in mind and work with it. And actually, as I mentioned, telemedicine might help. So organizing, scheduling, increased use of telemedicine may allow more productivity in this current paradigm. So in-office visits will require spacing the patients further apart. It might be unavoidable during procedures. We want to cram in as many procedures as we can because that's where us as pain physicians, make most of our revenue. But you got to be careful not to create an unsafe environment. You want to encourage non-contact ways of payment and scheduling. So after the visit, if the patient's leaving, you can explore things like PayPal, Venmo, Zelle for paying. Or your patient can just read out the credit card versus giving it to your staff to put it into the credit card reader. And then also for scheduling, rather than having the patient stop and make a scheduling appointment, they can go home and just call back later. Those are some things to consider explore, just making it more convenient to the patients, but also really avoiding close interactions and handing off pieces of credit cards and money and such. So next slide. So testing, we have a whole nother talk on this. I won't harp on this, but it's important to remember you're going to have to test for the presence of coronavirus in your patients, or at least consider it. You consider the risk that the patient might have coronavirus and what that risk is to you and your staff, as well as to the patient should it develop into full-blown COVID-19. Also, antibody has no role in preoperative screening. It's going to be testing for the antigen or the virus. So there's medical and legal reasons to test. Okay, so risk to the patient of the surgery increases if they have a complication afterwards or develop this COVID-19 postoperatively. Of course, they're going to have may have a bad outcome, and that could reflect on you for not testing and discovering that. And there's a legal liability in the hospital and to the doctor if the patient contracts the virus or spreads it in the facility. Hospitals are being very aggressive about testing, particularly for patients that are getting general anesthetics, because they don't want people to come in with an undetected coronavirus and then actually spread it into the anesthesia equipment and then potentially spread it to all the patients that follow in that room. So you're going to find hospitals are probably more aggressive at testing than what the CDC or actually the American Society of Anesthesiologists are recommending. And then even some hospitals, word's coming out that they're even testing surgeons. So that's something to consider too. It may happen, but it's more local, depending on your hospital. Next slide. Consent. So consent is sort of what I've talked about. You want a consent to release of liability from the patient contracting the virus just because they left their house and came to your office. And then secondly, a release of liability that they had a bad outcome afterwards, after your surgery or treatment, because they ended up having coronavirus that was undetected and it developed into COVID-19, and they responded worse to the virus because of your treatment. So those are things to mention. Well, next slide. As far as there are some examples of that, and you can find that on the OHSIPP toolkit. Next slide. Yeah, so the OHSIPP toolkit here contains examples of both risk stratification of patients and a consent. And you can see, go to the OHSIPP website, and there's the address for it. So there's risk stratification. You know, as we're hearing in the news, and as if you follow the medical literature, they talk about how patients who have diseases, so heart disease or diabetes, obesity, or poor physical condition, and those are people who are more at risk for developing, having a bad outcome with COVID-19. So this lists that risk stratification there, and they list other diseases too. And then depending on how many of these they have, of course, they might be high risk, moderate risk, and low risk. On the website, there's actually an algorithm where you can choose where to go, whether you want to do the surgery or delay. I didn't put that up here, but it is on the website. So you can use this information to help with deciding where you want to go further. Next slide. And the next slide is the consent form that they also have on that website. And essentially, it's a full one-page website consent, but in it mentions things that, we can't determine whether this pain treatment will affect you in a negative or positive way should you develop the coronavirus or COVID-19 infection. And then it also says that we can't guarantee that you won't catch the virus by coming to our office for this treatment. So those are the key points that consent has. You can download it off the OHSIPP website and then adapt it to your own use. Next page, next slide. I think that's all. So I'm going to turn it over now to our next speaker. Arti Singla is a physiatry physician who works with the orthopedic group in Cincinnati, and she's going to talk to you guys about maximizing efficiency in your office during this pandemic.
Thank you, Rick. So we're looking at maximizing efficiency in our new normal. So since the U.S. General set out the advisory that elective procedures should be canceled, actually have been 2 million procedures or surgeries that have been canceled as a result. This has affected ASCs as well as hospitals quite a bit, with 70% revenue being lost by ASCs since March. Hospitals have lost about $1.5 million per month. This assumes the US median, which is an 11-room OR with 58 cases per month, which is the average of elective cases within the hospital. ORs make up about 65% of a hospital profit margin, with elective cases making about $4,090 in profit. Next slide. So when we look towards May 1st and resuming elective procedures, we look at a recovery plan. And so there are different ways in which you can look at maximizing your procedure rooms. You can look at expanding horizontally, which means expanding how long you're open. This could be opening for 12 hours or even going into the weekends. You can expand vertically by using inactivated rooms, starting to use those again to do procedures or surgeries. There have also been suggestions for doing super Saturdays or super Sundays, which would be weekends full of large block time, 12 hours or so, where you can just run through and get a lot of these procedures done, but maintaining social distance. And this would be a great way to clear a lot of the backlog that you've accumulated between March to April. Next slide, please. So as you look at your roadmap, you want to understand how many cases you have, types of procedures, and which ones are more urgent. You're going to look at the risk stratification, as Rick talked about. And then you also want to balance this. You have your backlog from mid-March up into recently, but then you also have the needs of new patients or acute on chronic issues, because you want to continue to be able to service those as well as take care of your backlog. So it's important that you are communicating with your surgical staff, but then also with your office staff. We find that things are changing every day. Communication with patients seems to change daily, and so it's very important to make sure that everybody's on the same page so that everybody gives the same messaging. Next slide. And the communication with the patients is very important here too as well, because many are nervous. They want to get their pain relief, but they're nervous to go into ASCs, hospitals, offices, because they don't want to contract COVID going into there. You want to make sure you're communicating your plans for social distancing, making sure you're allaying their fears on how you're cleaning, how you're wearing masks, and keeping visitors in the car until the procedure or surgery so that there aren't as many people within each of these areas. When you are setting up patients for procedures, it takes longer than before. We're finding it's 2 to 3 times as longer as before, because you have to go through, if you are getting tested, you have to go through that whole protocol, and that comes up with a lot of questions. And then the whole telling patients about how you are keeping social distancing and all the different protocols in there, that also takes up more time. So it's very important that when you're scheduling these procedures, it's not like it was before. It's going to take 2 to 3 times longer for your scheduler or your office staff to help patients through this process. It's also important to post on social media and your website how you are following all of these protocols. And again, depending on your setup, as we want to maximize the number of patients that we can get through, we do have to follow all of the recommendations as Rick discussed before. But depending on your setup, if you are working with a hospital, it's really important to have this conversation with health system administrators, because a lot of them don't know what you do or how you do it. And so it's hard for them to differentiate what is going on in ORs and what's going on in pain procedures. You can also look at creative pre-op spaces for social distancing. Unused office spaces could be used. A consult room could be used for pre-op. We had one room that was being used for storage. It was a finished storage space, and we ended up converting it into a pre-op space, and that allowed us to run more procedures through the procedure room. Volumes are going to change rapidly as we do move into phase 2. In the first week of May 1st, they were allowing 2 interventions per hour. Within a week, we went to 4 per hour as we found more pre-op spaces to do social distancing. So the important thing is that plans that you make up, you have to be flexible and you have to be patient as we move along in this phase 1 through phase 4 time period. Next slide, please. Yeah, there we go. So where I am, they are testing COVID-19. They are testing anyone doing any procedures or surgeries within the system. So you have to be careful about when you schedule these patients if you are getting COVID-19 testing done, because it could take a few hours and it could be 3 days. In the first week, when we tested patients, the labs actually ran out of reagent, so they ended up going to Ohio State. And it actually took 6 days to get back because Ohio State system, their system crashed. So it took a while to get our tests back. So sometimes patients may have to actually be scheduled out later. So keeping that in mind if you are testing patients. And then after patients were told to be tested, then they were asked to be self-quarantined. That became a problem too, because as people were going back to work, you couldn't really self-quarantine. So they were asked to at least practice social distancing and wear a mask if they do return to work. Next slide, please. So telemedicine is a stopgap. As you know now, audiovisuals are billed the same as an office visit. So this is a very convenient way for patients who are somewhat digitally savvy. Still find it's difficult for some patients, even with FaceTime and Duo. At least with a telephone visit, it helps to maintain some type of contact, and you still continue to reduce virus transmission, as well as convenience for providers and office staff as well. Next slide. And as Rick talked about before, in-office visits have changed with all of the different parameters: social distancing, health and hygiene precautions, temperatures checks, screening questions, masks, and we wear gloves by staff. Ideally, patients continue wait in their car until their appointment, and then their visitors are strongly encouraged to stay in their car. But all this basically leads to, you can't see as many patients per hour as you probably used to. Next slide. We follow basically, if there are 4 rooms available for your patients, then we don't schedule more than 4 patients per hour. So it's basically 1 patient per room. That provides a good rule of thumb. And this also depends on how big your waiting room is. So as long as it can accommodate social distancing, this is the protocol we follow that allows you to stay within the capacity recommended. But you can use telemedicine to offset that. If you have 1 person maybe doing office visits, 1 person could be doing telemedicine, or you could be doing both. Sometimes it can be a little difficult going between the both. Next slide, please. What we found with telemedicine is that the busiest times match what you find in your own offices. Weekdays and morning hours are 9 to 11, we find are much busier. Later in the afternoon, after lunch, also continues to be busy. Still see no-show rates, even though telemedicine is very convenient. So reminder texts, phone calls the day before do help to remind patients that they should show up for their telemedicine visits. You can also change your office hours if you start a little bit later in the day. That seems to help as patients aren't sleeping. And this is also a low-cost opportunity to really test out different markets for business hours. Most people maintain the 8 to 5, but could a Monday evening or a Saturday morning be a better option? When things do get better, you may have a nice way to check for these options right now. Next slide. And then you can also use telemedicine if you have a lot of idle time with the procedure room. You can use telemedicine to fill in the gaps. So when we originally started, we were allowed to do 2 per hour, and so that gave a lot of idle time in between. So I started doing virtual visits in between the procedures, and so that became nice because you could still continue to have some clinic presence without actually being in the clinic, and then you didn't have these long gaps in between procedures either. And so by doing that, can you go ahead and go to the next slide? So by doing this, you can either scale up or scale down on the volume and number of procedures. So if you have more procedures, obviously you can scale down how many telemedicine visits you have. Thing that sometimes becomes tricky is you change from proceduralist to clinician and then back again. But during that idle time, you can add in some revenue by doing this. If you just even did 1 level 3 follow-up per hour for a total of 8 in a day, and you did 3 days of procedures per week, that would bring in about $600 per day, and at the end of the month, about $7,000. And you could pull different levers with this. If you did a few more new patients that were level 3 and the rest of them were follow-ups, you could bring in a little bit more revenue. And just to put that in perspective, when the PPP came through for practices that applied and got that on average covered $8,000 per month per employee, making $100,000. So this is just a nice way to at least help in the time that's idle to bring in some revenue. I'll turn it over to Alex then.
Thanks, Dr. Singla. So our country's response.
Is Alex Escobar. I'll turn it over to Alex. He's from Toledo. He'll be talking about prioritizing procedures.
Thanks, Dr.
Take it away,
Buenaventura.
Alex. I'll turn it over
And
to
Dr.
you now.
Singla. So our country's response to the coronavirus pandemic has been a great test of resilience, patience, and unity for our nation. Despite how one may feel about the actions taken by our government or lack thereof, it has been remarkable to witness the universal camaraderie among all healthcare providers. The state of Ohio has done an exceptional job in its efforts to flatten the curve. Being proactive, we were one of the first states to have a dedicated COVID hospital, and actually was there in Toledo, right next to our clinic, rather than reactive, while keeping health and well-being of our citizens a top priority. I was also quite pleased with the adherence to policy for discontinuing elective surgeries across the U.S. As hard as it was for providers and patients to delay necessary but elective care, on March 18th, in our state, all elective cases were canceled, and this was critical to allow for optimal healthcare utilization and conservation of PPE. Unfortunately, this may have delayed cases that should have continued. Albeit with the tremendous efforts by all Ohioans, we are now better equipped to manage both those critically ill and new cases that will continue for months to come. And in addition to the camaraderie amongst healthcare workers, we have also strengthened our own specialty of pain medicine by working closely at a distance together, as we are gathered here today by an expert panel of physicians who I trust dearly and respect to deliver up-to-date recommendations on the reopening of our clinics during this pandemic. It is with societies such as Ohio Society of Interventional Pain Physicians and AHSIPP, American Society of Pain and Neuroscience, as well as joint efforts by the ASA, ACS, and American Hospital Society or Association that have done tremendous job in providing guidance and recommendations, checklists, and risk stratification toolkits to aid us during these uncertain times. It's with due diligence, sound medical judgment, and the strict adherence to local policy that we'll be able to safely and effectively continue to care for our community of patients living in chronic pain. So what does it mean to reopen? Well, what it doesn't mean is simply business as usual. And we all need to be cautiously optimistic. As Drs. Buenaventura and Dr. Singla covered thoroughly in regards to risk stratification and practice efficiency, once we determine the medical necessity of a particular intervention, how do we proceed in today's climate? In order to resume elective cases for our specialty, we will focus on timing, case prioritization and scheduling, PPE, and infection control. It's imperative to understand that while our goal is to reduce the risk of viral exposure, it will never be zero, and this needs to be transparent for patients and providers. As of May 1, the Ohio Department of Health now relinquished some of its power back to physicians in regards to resuming elective procedures with recommendations that seek to limit the need for increased utilization of healthcare resources. This focus aims to limit the length of hospital stays, reduce aerosolization, with focus on interventions that do not require general anesthesia. This all sounds quite similar to our motto that we live by when we offer our services to our patients. Now, with full disclosure, I am a shareholder in our own local ASC, but I do feel that our single specialty surgery center is an ideal facility to safely offer properly screened patients intervention, as we rarely require general anesthesia. We rarely admit patients to the hospital following procedures or interventions, nor do we have any active cases that we are aware of the coronavirus. Next slide. All of these offer advantages over hospital-based procedures pre-COVID, but now are likely to be ideal scenarios for patients and providers. As in real estate, location, 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 and the same can be said for resuming elective cases during this pandemic. Site of service, in my mind, is the #1 consideration for resuming elective cases, as there is more control over the personnel and patients that visit the facility. A good friend and colleague, Dr. Ramu Naidu, described a scenario of canceled cases as pressure building in a container that will explode if the release valve isn't opened slowly. And this is a perfect analogy, as we now have a backlog of patients to schedule. And I don't know about the rest of you, but our phones have been ringing off the hook with patients' willingness to proceed with their scheduled cases that were delayed. And this is why we need a strict screening protocol, as continued delay for high-risk patients is inevitable. Dr. Dan's going to go into further detail in regards to testing. However, currently in our facility, we do not have the means or capacity to test every single patient that we provide care to. So what does that mean? What we've done in our practice is to prioritize the patients who have waited the longest and are not high risk using OHSIPP's risk stratification protocols. These patients all have a telemed appointment with their provider prior to scheduling the procedure to determine necessity. In addition, time has been dedicated to a single provider so that no other physician is active doing cases at the same time, as well as we group similar cases that require device rep support. We are making every effort to minimize the use of multiple different reps on the same day. And we have made our shortest time interval 25 minutes to reduce the overall volume. As discussed earlier, no patients in the waiting rooms. Patients are called in and are brought directly into pre-op holding. No guests in the waiting room. Thermal scans at the front door prior to entry, with the utilization and wearing of masks, maintaining 6 feet of distance when feasible. We also make every effort to do weekly inventory checks to ensure adequate PPE to support scheduled cases, as well as prioritize the opportunity for our local hospitals to be aware of our number and volume of PPE, so that if they do need or require the resources, they will be available to them. In addition, with PPE, we're making the best use of reusing caps and masks on the same day that are not soiled. What I do feel like has been the shining light through all of this is the need to adhere to strict infection control. Next slide. As healthcare providers, we are keen on universal precautions However, with the wake of this highly contagious virus, we now see an overwhelming adherence to hygiene. As I talk with you currently, my hands ache from dehydration, of repetitively washing multiple times a day and using sanitizers when applicable. Reducing the overall case volume allows for terminal cleaning between each case, which is imperative. Our recovery room has also utilized a step-down area where patients do not share the same space and can maintain more than 6 feet of distance at all times. And the routine cleaning of all high-touch surfaces is performed not just every day, but between every patient. As this current state of emergency is fluid, the only certainty is change. Be prepared to see these implementations for months to come, if not permanently, as we continue. The key to reopening and performing procedures during this pandemic is similar to managing intrathecal medication. And I think Dr. Dan will follow up this nicely, knowing that we always start low and go slow. Thank you for your time. I'll turn it over to Dr. Dan.
Are you going to jump
Next
back
is
on?
Tammy Dan. Dr. Dan is an anesthesiologist in Dayton area. She will be talking about testing.
So thank you for having me, and we've had some great talks tonight. I'm going to go a little bit more in depth about the screening for these patients, particularly for our procedures that we're doing. So who are we actually screening? We're screening everyone. That's what they're wanting us to do. And these are recommendations based off of the Centers for Disease Control, American Society of Anesthesiologists, the Anesthesia Patient Safety Foundation, and the Ohio Department of Health. Now, we know that those recommendations have been very fluid and have been changing quite a bit, but the ones that I'm using are actually the ones that were most recently provided for us, which was May 5th actually for Ohio, and for American Society of Anesthesiology was April 28th. It does seem to be consistent among the societies and the governmental recommendations. Nobody's really got an outlier there, so that's a good thing. And we are supposed to be doing our screenings prior to arriving at the facility, and again, once the patient gets to the facility. So they are recommending that we call these patients prior to having them come into our facilities and offices in order to screen them ahead of time. So how are we screening? What are the questions that we're supposed to be asking patients over the phone? So we need to ask them to look back at the last 2 weeks. So have they had any exposure to a confirmed case in that period of time? Have they had any actual fevers that have been over 100.5 degrees, cough, shortness of breath, recent loss of taste or smell, chills, muscle pain, headaches, sore throat, essentially a whole laundry list of problems that could be very non-specific. I mean, I've had patients say, but I have allergies and I know that these are from my allergies. And we say, well, we're just asking, you know, as part of our screening, if someone does say that they have not had any contact with a confirmed case and that they do have a few of these symptoms, but they have seasonal allergies and they know that that's what it is, we usually have them come into the office for their appointment, and we do make sure we ask them all the same questions and check their temperature once they get to the office as well. So what do we do with these screening results? So it really depends on your regional presence of COVID-19. So if you have a high regional presence, and we're talking someone who's answering yes to quite a few of those issues that we talked about before, then it says to refer for additional evaluation. And what we're recommending is that they call their primary care provider's office and proceed as they're directed from them. Now, if they're asymptomatic, then you can do the nucleic acid amplification testing or PCR test, and those can be done in Dayton. They can go out to the UD Arena. There are various places in each community that they have designated to do these tests at. And as far as the tests go, that nucleic acid amplification testing is not simply just I swab and I wait and read it later. No, it takes this actual machine that you see in the picture here, and this one that I showed is the Abbott ID rapid test. There's also another test that's a PCR test that's from Roche, and this is going to detect a current infection. So this is only going to tell you, is this patient currently infected? That is what it is looking for. And this is a lot of the testing that our local hospitals are doing. So the other test is the antibody testing, and we've heard a lot about this in the news lately. This is only going to tell you if the patient has a previous infection. So they could have had the infection 2 months ago, and that's what this is going to tell you, because the antibodies don't develop until they're into their second week of symptoms. So it's been largely understood that this test has no role in our perioperative screening for our procedures. And not all infected patients may develop antibodies. So that's another thing to take into consideration. If someone tells you they've had this test and it's negative, well, not everybody develops the antibodies. The other caveat as well is that there's potential cross-reactivity with other coronaviruses. So they could have just had the common cold coronavirus and they may wind up testing positive. Some other things to keep in mind about these viral tests are that at the time that I researched this, the SARS-CoV-2 sensitivity was only 70 to 90%, which means that you've got a possibility of about 30% of all infected individuals that can be missed. And also when we're asking about our screening questions for our symptoms, viral transmission can occur up to 3 days before these symptoms start. The viral shedding can also go undetected for 21 days post-infection. So you're looking at a good 3 weeks here that people can be shedding virus and not even know it if they're asymptomatic. So what do we do if we're in a low regional presence? And I would probably say that my local region would be considered low. My county that I live in has about 50 cases, and where I practice at, a little less than 400. So if they're symptomatic, again, you're still going to refer them for additional evaluation, and that means sending them over to their primary care. If they're asymptomatic, the recommendation is to go ahead and proceed with surgery with no further testing, and this would envelop all of our pain procedures as well as our surgical procedures. And just since we're talking about Ohio, I did go ahead and give us the latest map that I could find that had the regional prevalence. So if you're like, I have no idea what my county's prevalence is, and you're here in this state, you can find out what it is. So, you can see that if you have a major international airport in your town, chances are you probably have a pretty higher prevalence compared to other regions that do not. Next slide, please. So how does this compare to the recommendations from specifically the Ohio Department of Health? Well, they do theirs a little different. They change their testing stratification into 3 different levels. And this is, at least for the first 2 levels, fairly consistent with what the CDC recommends. We do kind of veer off a little bit different course when it gets to the 3rd priority. So their first priority that they're saying are hospitalized patients and healthcare personnel that do have symptoms. So this kind of seems fairly obvious that we obviously want to be testing people that we think have it. The second priority are going to be people at high risk of complications. So this point, we're talking the over 65-year-olds, people that have underlying conditions, first responders or critical personnel with symptoms. Now, nursing home, long-term care facility residents, they fall into this high risk of complications. So they are saying they're also congregating together. So let's go ahead and test the people that do not have symptoms as well. So that's where we get a little more overarching and start trying to test more people. The third section is for people that are receiving procedures regardless of symptoms again. So you can see most of our patients that we want to do injections on or put spinal cord stimulators in, they're going to fall in that priority 3, because we're not going to be doing any procedures on people that actively have symptoms or actively have the virus. So how are some of the local hospital systems dealing with this? And I gave us a snippet of hospitals that are around the area that I knew of other physicians that are working there. My actual system that I tend to do a lot of surgery in is the Kettering Health Network based in Dayton. And they pretty much said they'll follow the policies outlined by the Ohio Department of Health, but they do have limited tests available. So they're not overarchingly testing all surgical patients, but again, the counties that they're covering have 50 cases and less than 400 cases. So we're not a very high prevalence area. Premier, though, which is also in the Dayton area, is testing for all procedures that require anesthesia. So that would probably knock out most of our injections that we're doing. And they're testing people 48 to 72 hours prior, and the patient is being requested to self-isolate until the day of procedure. And they're just strongly recommending other procedures get tested, but they're leaving it to physician discretion. If you move further south and go down to Cincinnati, at the Mercy system, they are definitely testing all patients 72 hours prior to the procedure and having them self-isolate until the day of the procedure. And at the University of Cincinnati, they're also doing the same thing for their actual surgical procedures. And we're going to go to Amal here.
Thank you, Tammy. Dr. Amal will give us an update on the Ohio State Medical Board with changes they made with regards to the coronavirus, as well as follow up with some financial strategies for surviving the coronavirus pandemic going forward. So I'll turn it over to Amal.
Thanks, Dr. Buenaventura. Great presentation by everybody so far, and thanks for taking the time tonight. Hello, Ohio. Let's move on to the next slide there, and I'm going to discuss about options to capitalize your business, but ultimately you're responsible. These are just my opinions. Good to consult with a lawyer or banker. So let's talk about Ohio Medical Board updates first. The website med.ohio.gov has very comprehensive information right on the homepage about how to handle COVID patients. And it was nice and it was fun to hear about, you know, ASPN's opinions or other societies' opinions. But at the end of the day, those are opinions. And quite frankly, a lot of them are bullcrap, to be totally honest. There's one opinion that matters, and that's the med.ohio.gov opinion. Why is that? Well, that's because the Ohio Medical Board is the person that gives you the license, that gives you the ability to practice, and they're also the organization that can take it away. So if you had to follow one guideline and one rule, that's the one you want to follow. And actually, Dr. Dan did a really great job of breaking down the testing from the Ohio Department of Health. I really suggest that you look at that. And the other thing that we're doing at the medical board is we're sending out emails, and you guys are probably getting a ton of emails, let's be honest, about all this stuff. But they're sending out a ton of emails about how to open up your office. And we sent one last night with a toolkit about how to open up the office, how to do testing and all that stuff. So please look at that. It comes from State Medical Board of Ohio as the sender. So just look that up in your email, whatever email address you use to get your medical license, that's the email address to use to look it up. Telemedicine, we've heard about it a lot. It's here. I don't know if it's here to stay, because one of the problems we have is the Ohio Revised Code has some rigid definitions of telemedicine, and particularly physical exams. The State Medical Board of Ohio suspended those rules, but those rules are still on the books. So after all of this list, we're going to have to revisit those. But there are some important things that have to do with a pain patient in particular. One is, if you have a patient on a morphine equivalent dose greater than 80 morphine equivalent dose, remember, according to rule, the chronic pain rules that are in the Ohio Revised Code, you have to have a face-to-face physical exam every 90 days. Now, we have suspended that rule currently, but just keep that in mind, because I know we can all lose track of that as we move forward, particularly those who write opioids. So at a minimum, try to do that with a telemedicine visit, or at least document that you attempted to try it. The medical board's not really going to prosecute anyone over this during the crisis, but it is something to consider. The pain prescribing rules have changed a little bit. We made them a lot more liberal as far as the medical board. We suspended a lot of the pain prescribing rules, and you can see those on the medohio.gov website. So it's important to go there and check it out. You know, some things like requiring a face-to-face physical exam has been suspended, and just a lot of the general rules about prescribing, when and how you can prescribe. We did the same thing for CME. In other words, we suspended the CME requirement for this year in 2020, although I do encourage you to continue to get that CME. The Ohio Medical Board has an automatic audit that's computer generated for 3% of all applicants per year, so you could get audited. The way we do CMEs is a rolling 2-year for 50 credit hours of category 1. So just keep that in mind as you move into next year. And it's always good to get CME, but just know that for the time being, they have suspended the rules, and you'll hear updates on what we're going to do soon. In fact, our medical board meeting for May is on Wednesday, so we'll have a lot of updates at that time, and we'll probably send out another statewide email on that. We've already heard a lot about elective procedures. Let's move on to the next slide. I'm going to be talking to you about things and options and ways to capitalize your business. As you know, the Medicare Advanced Payment Program was suspended here in Ohio because they've already given out all of the amount of money that they have. For those of you who got it, it's an interest-free bridge loan that has to be repaid after 120 days, and it's repaid based on your future Medicare claims. Next slide, please. There are other incentives that are available. The HHS stimulus program gave an automatic deposit based on 6.1% of your billing last year, and those were automatically deposited into your accounts. There's a way to attest for that, which you'll see on the slide coming up, but there is a second round of stimulus money, $20 billion, that should be coming out here soon. But in order to even qualify for that, you have to go to this website, the hhs.gov website, and you have to go in there and put in last year's tax returns if you have them. If you don't, you need to talk to your accountant to get them in. And you also have to estimate your approximate dollar loss for March and April due to COVID, and then they use that as a formula to start distributing money. I don't know of physicians in Ohio that are pain management based that have gotten this money. I do know some physicians in Ohio, in Sandusky, for example. I know of a plastic surgeon who actually got the second round of this stimulus, and I know pain physicians in California have also received the second round of stimulus money. Hopefully we'll get it here in Ohio for those of us that have applied. Here's the website to attest to the stage 1 of money that you got automatically deposited into your accounts about a month ago. It's at covid19.linkhealth.com. It literally takes 5 minutes to do those steps as long as you know your tax ID number. You literally have to attest to verify that you got the money, and secondly, verify that your practice was affected by COVID. Next slide, please. So please make sure you go ahead and attest to both of those things for the phase 1 and phase 2 of stimulus money. Remember to be safe about how you open the practice. No mask, no service, right, is kind of what we have heard in Ohio, although they've liberalized that for customers. But please, as a physician or a physician practice, make sure that you guys have masks, because that's going to be a difficult complaint to defend if somebody does complain about you to the medical board. Remember to conduct those daily health assessments, assess for fevers, and maintain good hygiene. Next slide. You know, all the stuff that you've been hearing about is important to do as you open up. And the key thing here is to make sure that you are following the rules that are distributed by the medical board above all else. I can't stress that enough, because Ohio and every state's going to have unique rules. And I know you're hearing stuff from different societies. I know that ASPN is putting out a task force newsletter and all that stuff, but please just be very careful, because remember, those things may not specifically apply to Ohio. And I would hate to see you guys get into trouble because you're following a guideline that's an opinion written by 1 or 2 physicians who may not know what's happening in our state. So just remember, that if an exposure occurs, you do have a fiduciary duty to immediately report it to the health department. There is an anonymous tip line out there. So if you don't follow the rules, your employees are encouraged to whistleblow against you. So just keep that in mind. Working with the health department or your local community to do contact tracing. If you do have an exposure in your clinic, they do recommend shutting down the floor, or at least the area where you believe the exposure occurred, for some deep sanitation, and then you can reopen with consultations with your local health department. Next slide, please. So it's important to follow these rules that have been given out. The other thing that I made here, I was part of that AHSIPP task force that came up with the risk stratification guideline. And remember, again, just like everything else, even that's an opinion, you can follow it and use it. But this toolkit's kind of neat. So what it is, and this is available on the AHSIPP website, for anyone that has a procedure suite or surgery center, it's a yes or no check mark box that you can fill out just about things like, do you have social distancing? Do you encourage hand washing? Is everyone wearing a mask? Does your RFA machine work? Is your CRM properly functioning? Is everything, up to date with, your radiation certifications as you reopen your practice? Are vendors aware that you're open? Is the medical staff prepared? And it's just a simple yes or no checklist that you can go down. And I highly recommend that you do that, because if something does happen, if the Department of Health does come in because of an anonymous tip, or you have some sort of problem with the patient complaining about you, at least you have something in your hand that shows that you made a good faith attempt to ensure patient safety. And that's really important and can really protect you from getting into trouble. So it's something I want you guys to do and look at is consider to use this ASC checklist, consider to use the risk disclosure document or consent form that AHSIPP also has. And with that, I'd like to open it up for questions and answers. Thank you.
Good evening, everyone. If you have a question, please feel free to submit that in the chat box that you will see. We are open to questions and you can direct one to anyone on the panel. Dr. Buenaventura, we have a, let's see, it doesn't look like we have any questions that have come in yet. So again, go ahead and type if you have a question, please feel free to issue one now.
While we're waiting for questions, I did want to clarify one thing about
during the
antibody
presentation,
testing.
there was yeah, go ahead. That's what I was going to talk about, but I'll let you go ahead and address.
Oh, sure. You know, regarding antibody testing, it is accurate to say that antibody testing serves no role in screening patients for procedures. However, there could be some benefit to antibody testing. In particular, if you have a patient who had a known COVID infection and has recovered from that infection and is asymptomatic and has positive antibodies, or you have somebody that you know has recovered completely from a previous illness and has positive antibodies, that actually does place them on the low risk category for a COVID reinfection, according to the AHSIPP risk stratification guideline regarding elective pain management procedures. So I wouldn't necessarily use that as an only test, but if you do have it, a positive antibody test could provide some value to you. A negative antibody test provides no value to you whatsoever. I just wanted to clarify that one point.
As of now, we don't have any questions from the webinar attendees, but there wasn't a question earlier that a doctor had given, and I don't know if anybody from the webinar panel can assist. But basically, a doctor practicing on a border town, question about whether a patient can cross the state lines, come to their office for a visit, and be seen and go back home, or you know, do they have to follow some kind of quarantine isolation for 14 days just because they're crossing state lines? I don't think that's an issue, but I'll see if anybody has any comments or suggestions. I know we all basically
I can actually take that. So I cross the border. I cross the border every day as I live in Michigan. And Toledo is only about 45 minutes from where I live. The state of Ohio recommends that anyone entering Ohio quarantine themselves for 14 days. So I would say utilize your telemedicine appropriately, as you can now see patients from out of state. However, if they were to come into the state from an outside state, they are recommending 14 days of quarantine.
All right. And as of now, I don't have any other questions. At least, let's see here. Do outpatient procedures in low risk categories require testing? I'll turn it over to Tammy Dan.
Based off of the recommendations, if you're doing a procedure, if you're in a high risk area or a high prevalence area, they are recommending that you get some sort of testing done for any procedures at all. If you're in a low prevalence, low risk area, then they are saying that you just do the basic screening and that you can go ahead and go on with the surgery or the procedure. So you just have to look at your local, at what's going on in your region.
Okay. Here's a financial question for Dr. Soin. Basically, as far as the second round of HSS stimulation, if you have any idea how they're calculating and what they're paying out, if it's percentage based or any relation to what did your friends or your associates get in relation to their first payments?
So it was approximately, so my friends that got it, it was approximately 2/3 of what they got the first payment. I don't know the exact model or number that they use, but I do know it's based on how you fill out your disclosure regarding income lost for March and April. So it's based off a percentage of that, although I don't exactly know the specifics. And I don't even know if we're going to get it at this point, because I mean, you know, this was announced a while ago, so you know the days are ticking by. So, and I applied for mine relatively early, and I haven't heard anything yet. So fingers crossed, hopefully we'll get it.
Although you mentioned that they want to look at the financial hardship it caused for March and April. Well, April just finished 10 days ago, so accountants are just giving us those numbers now. So most people, you can't even provide the full documentation or data until just now, the last week or so. And I'm waiting for my bookkeeper to come in to finish up my details for April. But I do know that just from volume, my volume was down 70% for the month of April and probably down 40% for March.
Yeah, no, that's accurate. But if you look at the website, when you fill out the disclosure form, it does ask for an estimated loss. So, you know, I presume that you would just base it off an estimation. And they actually ask for the previous year's tax returns and income statements just so they can verify with accuracy. But I know some entities, not necessarily small private practice pain clinics, but large hospital networks were filling out a very large number for approximate dollar loss. I know one local health network filled out the approximate loss for 2 months is $35 million. So, I mean, obviously, those things will likely get audited and have some pretty steep requirements.
All right, as it is, I don't see any other questions coming through. I guess we're going to end it on about the hour. I just put out some final pointers and recommendations. Keep an ear out for announcements about the OHSIPP annual meeting, which is scheduled for August. As of now, we're still planning on having it, but it's still up in the air. We don't know. And of course, the AHSIPP meeting, the annual meeting, which was originally for April, has been pushed back until September. And keep an eye out for that one. That seems to be a go unless things change. So keep an eye out for those emails and mail-ins, and hope to see you either in Dallas in September or in Cincinnati whenever we have ours. Plan on August, but it could also be pushed back or flipped to after the AHSIPP meeting. And with that, I'll end it. Thank you to everybody, and we'll see you next time. We don't have any plans for any more webinars at the moment, but we may schedule one in the coming weeks if there's a demand for it. And thank you, everybody, and good night.
Thank you.
Thank you. Good night.
Thank you. Good night.